Well, obviously, from an anatomical point of view, the breast belongs in front of the pectoralis major muscle. So clearly it does make sense to try and work in that direction to ensure that in future implant reconstruction is undertaken with the implant in front of the muscle. This is not a new idea, it's an old idea and has been phased out and wasn't properly evaluated and is now making a comeback and is currently being tried at various sites, but it needs proper evaluation with proper trials. And what I've done is I've looked at the existing evidence. So my own view is that it should only be offered to patients as part of a clinical trial until such time as we understand it better, know what the complications are, and can offer it to patients with the possibility of telling them what the complications could be. When I talk about breast reconstruction, I always remind myself that it's important to take one step back, and when a patient is referred to me for a mastectomy and a breast reconstruction, I always consider whether breast conservation is a possibility. And quite often it is, with modern techniques. So the first step is to offer breast conservation to patients who do not really need a mastectomy. If a patient really requires mastectomy, then it's important to offer them breast reconstruction, and in most cases in the immediate phase, because you can preserve the skin and you can get a better cosmetic result. Obviously the options are implant or autologous, but implant reconstruction is the simplest option, and it's important to always consider the simplest option first before considering other options. I set up the first prospective trial of acellular dermal matrix for implant reconstruction about 5 years ago, and the results have now matured, and I'm about to publish the 5-year outcome data on POBRAD. And while we were evaluating POBRAD, I set up a second multi-center trial called POBRAD-M, and POBRAD-M has accrued all the patients in January of 2017, and we are now following them up. POBRAD has taught us what the complication rates are. POBRAD-M has enabled us to compare the complication rate of patients who are suitable for implant, but some of whom choose autologous. And in POBRAD-M, 62% of patients chose implant reconstruction. So the vast majority of patients in the UK still choose implant reconstruction, similar to the US. Well, I would be very interested in setting up a trial of pre-pectoral implant reconstruction, but I'd also be happy to recruit into another trial if other centers are doing it. So I'm pretty flexible about it, but I think pre-pectoral reconstruction is worth evaluation. There are a number of very, very interesting devices that are coming out. I have experience with intraoperative radiotherapy, a technique that I've been involved with for nearly 17 years now. I've also got experience with high-intensity focused ultrasound and a number of other techniques, including the magnetic technique for guidance for cancer surgery, a technique that I actually developed. So all of these techniques are very exciting, but I think what is even more exciting is to refine the way in which we develop things, because it's not good that companies are CE marking or getting FDA approval on a product with no experience on patients. And then us surgeons are prepared to just take one and teach one and use one without proper evaluation. And I think the most exciting development is going to be proper evaluation of devices. I had an interest in medicine when I was 12, and in cancer surgery in my first year at medical school. And that interest in cancer surgery developed very quickly into an interest in breast cancer surgery, because breast cancer surgery is an area where there have been a lot of trials undertaken. It's a very common cancer, and it's a very thorough area of surgery where a lot of clinical evaluations have been undertaken. So it was natural for me to end up in breast surgery with an interest in surgical oncology. Well, the training of young surgeons who want to choose breast surgery is quite tricky at the moment, because in the UK, the undergraduate education in medicine, some medical schools have taken surgery out of the curriculum. And when students graduate, they then have to seek out breast surgery to have an experience in it. So it's become very difficult for breast trainees to become trained in breast surgery. And my advice to them is persevere, because it's a very, very satisfying and gratifying career. There are a lot of journals, and there are a lot of surgical journals, but I think there is still a need for a very good breast journal that would encompass both the benign work that we do as well as the cancer work that we do. So the difficulty for breast surgeons is sometimes that they have to submit their cancer work to an existing cancer journal that is quite difficult. Some of them are very competitive. And when they have benign work, then they get embedded in the literature because there aren't a lot of journals that will take them. So there is a space there for a very good and thorough breast journal, and this time is right for the annals of breast surgery, and I think it's a very exciting development.